You're listening to Our Daily Show with CJ Nasello on RiverBender.com. Welcome back to Our Daily Show. The time is 9:18 on this Monday morning. And a great conversation comes our way with OSF Healthcare. Dr. Dennis Sands is Chief Medical Officer. And Doctor, thank you so much for joining us on the Zoom call today, and really excited to get your insights on just such a very awful disease. Can you hear me?
Yes, can you hear me?
Yep, I got you here now. And Dr. Sands, thanks for joining us. And you know, it's always a great time to raise awareness and insights, especially when we're talking about something like cervical cancer. And Doctor, as we start this conversation off today, let's just give, if we could, an overview of what cervical cancer exactly is.
Yeah, good question. So essentially what we found is, years ago that most of the cervical cancers are caused by a virus. Called the human papilloma virus, or HP, P as in Paul, V as in Victor, HPV virus. And so we found that that is the main etiology for these. And one of the great things about, finding that or making that discovery is that we're able to, just simply do a pap smear, which is a screening test. And now we have a super sensitive way to do that. So they can be done less frequently. That will actually detect that virus. And therefore it is much more sensitive and specific for the virus, and able to actually catch it and find it and treat it very early, while you just have a precancerous condition, or as we call it, a dysplasia or dysplastic position. So the great thing is if people just get their PAPs like they need to, then they're able to catch the precursor lesions, which are caused by the HPV virus. And then we're able to treat them before they actually ever develop cervical cancer.
Well, and it just seems like, Doctor, that going in and getting those regular screenings is vitally important. And I also saw something, and would love your insights on this, that women between the ages of 35 to 44 are most likely to receive this diagnosis.
Right. Yeah, it's actually the group where we'll see it the most. And, we see about 14,000 cases of cervical cancer in women per year. So it's very real. That being said, we've done quite a bit better in the United States over the last few years with people actually getting their pap smears more frequently. Mm-hmm. And then also with the advent of the HPV vaccine, which will prevent that virus from getting, into the person or, onto their cervix in most cases, or wipe it out quickly. And then that has reduced the cervical cancer rates for young women who get the HPV vaccine. It'll be beneficial or protective for about 90% of those HPV viruses that are out there.
Well, and that's where I find this so fascinating right now in this point in the conversation is the fact that a lot of this just from what I read, a little bit of what Randy sent over, just highly treatable in those early stages. And I'm sure years ago, before maybe this was so commonplace, it's amazing to me to see just the evolution of healthcare, really, Doctor, and how preventable maintenance can truly go so much further in your life than you think about it.
Yeah, this is actually one of those kind of breakthrough stories in medicine, right? Where they found years ago, they're like, what causes cervical cancer? And we've now actually, elucidated that, most are caused by this human papilloma virus or HPV virus. And the beauty of that is you can catch it early, therefore you can treat it early and prevent, the actual development of cervical cancer. And likewise, with the HPV vaccine, you probably have heard, listeners have probably heard the term, Gardasil is one of the vaccines. And with that, you're able to, inoculate people and prevent the, acquisition of the virus or, growth of the virus in, a lot of cases, and therefore prevent that progression of ever occurring, into cervical cancer. So pretty neat stuff. When you look at basic sciences, this is one of those success stories. We hear a lot about those things we're still studying. We haven't quite figured it out yet. But this is actually one of those real interesting ones where immunology and molecular biology, have paid off.
Well, and honestly, it's really fascinating just to hear that evolution just from, someone who doesn't study medicine to see, how far we've come on some of these things. And, for women out there that maybe don't understand the process or, how these screenings work, what do they look like and how early should we start screening for this?
Yeah, so years ago they used to say, you need to start at, age 18. What we've kind of found is that's a little too soon, especially for young women who are not sexually active. So we're really looking at 21 years of age, or when people become sexually active is the best time to start screening. The nice thing is, you can now screen every 3 to 5 years, depending on which screening modality you use. But if you use the super sensitive Pap smears that we now have, which is actually a liquid-based medium, which is kind of cool. It actually looks for the virus that I was just talking about, and those different high-risk HPV types or subtypes it's actually looking for. We know there's basically about 100 of those that are the real nasty ones that can, get into a woman's cervix and put her at risk for later development of cervical cancer. So by just doing those screenings, if you do the dual screening, you do the Pap with the HPV, a virus or molecular screen, and those are normal, you can actually just bump those out to every 5 years, which is pretty cool because women hate those exams anyway.
Right.
So the less frequent, the less, obviously often you need to do that, the better all the way around. But also in that technology is so super sensitive that it basically captures, almost everything. So that's, a far cry and a dramatic improvement from what we had many years ago, where we'd have, false positive rates of, 30, 40%, or false negative rates, I'm sorry, that high. And you would just really wonder, gee, how good is this screening modality?
Right. Well, and, you said something a couple of seconds ago that really just stuck to me. Did you say there was hundreds of different types of HPV?
Yeah, there are many different ones,
Wow.
and there's about 90 to 100 of the ones that we've identified that are kind of the main ones that we look out for. We know that, off the top of our heads that some of the main subtypes, 16, 18, 31, 33, 35, we just know them because we read them on the reports every day. But they're actually looking for a lot more of them.
Wow.
And they catch those, and they'll actually, one of the results is just, are there any high risk subtypes that we've detected? And that's, been a real benefit in medicine for us to be able to test for that.
Well, let's say someone does get their screening and it doesn't come back the best. What do those steps look like?
Yeah, so it's great that you got it done because then you're going to detect it. So let's just say it is positive for one of the high risk types. And then we would say just follow up with your doctor, and they'll talk with you about that. And you may have to just undergo a simple look at the cervix through a microscope, which is real easy to do, and that's called a colposcopy or colpo, COLPO. That just means looking at the cervix with a high-powered microscope. And then we're able to just put literally a vinegar, acetic acid on the cervix with just a big Q-tip. And if any of those areas light up through that little colposcope, which also has different lenses and magnifications on it and color filters, which allow us to see really well at a higher magnification, we're able then with that device to see are there any areas on the colposcopy that need a biopsy or not. And then we would, if we need that, we would take a small biopsy, send that off, and then of course that's the definitive answer. The beauty of that is though with the molecular screening, the PAPs and the colposcopies, we're able to catch and treat these things before they ever develop into cervical cancer. You worry about folks who don't get the screening done because those are the ones that do sometimes come in with the cervical cancer, and they come in with bleeding or discharge or something, and they have. When's the last time you saw your, gynecologist? 10 years ago, and those are usually the bad stories.
Well, and I can only imagine, and I think it's just great for, us to kind of drive that point home, how important it is to go and get those screenings done regularly, when you're scheduled to do them. And I was wondering too, is there multiple types of cervical cancer?
There are actually, the two biggies are like a squamous cell carcinoma, and then an adenocarcinoma is about 10 to 20%, and the squamous, which are the cells on the surface of the cervix, those are the bulk, like 80 to 90%. So those are the ones that we see the most of. The adenocarcinomas are more kind of transitioning into the inside of the cervix and then go up, actually, kind of up towards the uterus itself. Cervix, as listeners probably know, is the lower part of the uterus, which is, at the apex or at the top of the vagina. So you can actually just see it on exam, which makes this, a good thing you can screen for and you can treat for before it actually gets too bad. But yeah, so it's about 10 to 20% are adenocarcinomas, and about 80-90% are the squamous cell carcinomas that we tend to see more of.
And, with that being said, too, what are some of those, signs and symptoms maybe look like? Just because you hit on a few, and I just, in case there's a little bit more to that, is there, been some pretty common symptoms that folks have that you kind of know lines up to what possibly could be a cervical cancer diagnosis?
Yeah, good question. So symptoms would be things like, bleeding out of nowhere, like vaginal bleeding that's not at the time of the menstrual flow, or a vaginal discharge. Certainly, it could be a sign that wasn't there, especially if you haven't had a PAP in over 5 years. Discharges that weren't there or are new. Pain with intercourse, could be obviously a problem or something to look for, or postcoital or after intercourse type bleeding can certainly be a warning sign. The biggest thing I think we always try to tell people is just be sure you've had a PAP in the past few years. It's those folks that have not that are the ones that are at high risk, and that we'll sometimes see come in with some of these signs we're discussing right now, the bleeding, the discharge, the pain after intercourse, and things along those lines.
And, when it comes to, some of the complications of cervical cancer too, doctor, what do some of those start to look like? Like when it comes to is, like kidney issues, or is there any other ailments that are attributed to a cervical cancer?
Yeah, I mean, once it gets progressive, it can actually start to grow, into the inner part of the cervix, and it can start to grow into the uterus itself. People could feel pressure on their bladder or lower abdominal pain. By then, it's pretty advanced. You might need radiation to treat those. But still, they're having some incredible results with chemo and radiation, even for advanced cases. And so, those are some of the symptoms. If it becomes even more advanced, the tubes that come out of the kidneys, which are the ureters, are only about, that then go right into the bladder, pretty close to where the cervix actually lives. Those are only about 2 centimeters from the cervix itself.
Wow.
Which is really problematic, because then if the cervical cancer started to spread laterally, it can actually encroach and get into that space where the ureters are, which could back up and kind of close off that ureter, which is called hydronephrosis, which could ultimately cause kidney damage, because then the kidney can't drain. So these things can get really serious, if you don't treat them or catch them. And it's just so sad when that happens, because really all those patients needed to do, or those women needed to do, is keep up with routine screening for pap smears.
Well, and that's where I keep going back to that first part of our conversation, but it's incredible to me that this is, like you said, something that, science has actually, found. It's not a debate, and it's just really interesting to hear, how this is really progressed when it comes to treatment, and now these new types of screenings and ways that you can really prevent this and take care of yourself. And when it comes to treatment on cervical cancer, what does that normally look like? Because I'm sure there's various stages of this, but what does that kind of, baseline kind of start at when it comes to tackling this?
Yeah, so really you just want to look at, your standard kind of tumor markers or discussion, what's the stage, of it. So, what kind of tumor is it? What's the cellular type? Like we were just talking about squamous cells versus adenocarcinoma, or those are the columnar type cells. They're actually the shape of a column, hence the term columnar. Is it squamous? Is it columnar? Are there any nodes, lymph nodes involved? What's the size of the tumor? How big or small is it? And then, we always refer to the, metastases, or M. So you'll hear us refer to, TNM, tumor type, tumor size, and, nodes, lymph nodes, a positive or negative, and then the M for any, metastases, any place else in the body. And obviously those are the most severe when those occur. There's been some new literature. It's kind of interesting looking at, tumors, particularly of the endometrium, the upper part of the uterus, which are, some of that methodology is actually changing and becoming more specific for the way the tumors behave.
Wow.
So even just the whole development and growth in the knowledge of oncology and cancers in general is always growing, is always, developing by leaps and bounds.
Well, and see, I think that's a fascinating follow-up too, because, how do you guys stay up to date on all of these new developments? Because I'm sure in your field, these change almost constantly, I would imagine.
Yeah, they do. It's generally not, you don't typically see things change every year.
Right.
Some do, but so we're obviously required, being board certified in obstetrics and gynecology, to keep up on the continuing medical education to maintain our board certifications. We actually have to take, tests for those, or small exams or proficiency exams. And then every 6 years, you'd be required, if you didn't get like above a 90 or 95% on those tests, you'd be required to take another like 3-hour exam. Mm-hmm. To maintain your board certification. So to answer your question, the American Board of Obstetrics and Gynecology keeps you on your feet to be sure you're keeping abreast and reading, of all the changes, which is why, there's so many different types of doctors, right? You can only keep up with your own specialty while you're practicing and working and taking call, and while you're trying to read and keep up with the latest changes and developments.
Well, and it's just, really interesting to note that too, and just see that, what goes on behind the scenes after we're maybe after our appointment's done with you. So it's really just fascinating. And Doctor, when it comes to pregnancies with cervical cancers or, HPV, what does that look like down the road? Because, when I see the 35 to 44 range, some of those folks, especially in their mid-30s, that could be the time where they're thinking about that future. What complications go into that?
Yes, obviously, if they're doing their screenings and everything, then you would have caught it early. You would have treated it, and you always get a routine Pap smear with new obstetric appointments. You always verify that that's up to date, so we would catch that. You always do an exam, so we would catch that. But I guess it sounds like your question is, what if they had a cervical cancer and they were pregnant? And most of the time, if those are early, they'll have a big discussion with their physician. We probably typically have them see the GYN oncologist, which is a subspecialist, as well as then they would be considered a high-risk OB or high-risk pregnancy. So then we'd have them see a maternal fetal medicine specialist. We actually partner with SSM, St. Louis University, on those. It's St. Mary's in Clayton. And, then they would determine, is this low risk enough right now or early enough that we can let the pregnancy continue? Or is it one of those, really dramatic or very sad cases where the risk is just too great to the mom, depending on how far along they are, and then some, real deep kind of critical conversations need to be had on, what are the risks and odds of continuing those pregnancies. So you see, it gets pretty difficult in those situations, and thank goodness they're rare. They're very rare that we would see those, because women are keeping up, as they've seen the gravity of this. They are keeping up with their PAPs and annual screenings in most cases.
Well, and honestly, that's at least where you're seeing that trend where they are keeping up with it. And here locally and with OSF, what are you guys encountering when it comes to cervical cancer? Just here locally, what are you seeing?
Yeah, we do see it, unfortunately. We do see cervical cancer usually presents with bleeding or a first visit of a patient that hasn't seen a doctor, had a Pap smear in 5 to 10 years. So we see the standard kind of presentation, that you and I were talking about just a little bit earlier. And it's sad, right? It's very sad. And because then you're kind of trying to play catch up on those folks. Where if you could have caught it early, perhaps the outcome might have been better. That being said, with early grade cancers, like the stage 1s, sometimes you can just treat those with a radical hysterectomy or radiation and chemo radiation, and you can have really good outcomes with those. As they get more advanced, like stage 3s and 4s, that's where the risk of recurrence goes up, and the risk of cure, goes down. So obviously early stage, like 1 and 2, have a much more favorable prognosis.
And, just a quick follow-up to that too, because we were talking about that age range. Are you seeing that? Is that matching what you guys are kind of encountering? If you do at OSF, is that 34 to 45 kind of what you're seeing more prominence in, or is it a different age range for you?
No, that's it pretty much. Yeah,
Wow.
we're seeing that 35 to 44, 35 to 45 tends to be when you kind of see those. Interestingly enough, 30 and under 30, the immune system in the body is actually incredibly strong. And most of those HPV viruses that you might have previously detected on a pap smear, that are the low grade kind of viruses, they haven't grown into the high grade, which is actually a cervical cancer precursor. A lot of those low grade ones in women 30 and under, their immune system will defeat that virus and just wipe it out completely.
Wow.
So you really start to get higher risk. You start to see that once you get beyond 30 years of age.
That's very interesting. I would never have suspected that. Is it just, and I know we're talking cervical cancer here, but is it just women specific for 30 and under, or is that across the board for bodies?
Yeah, well, I mean, this is just with cervical cancer.
Okay, that's what I wanted to add. Okay.
Yeah. So I can't speak to others. But certainly, any kinds of risky behaviors like multiple partners, early age at first intercourse, so less than 18, that puts you at higher risk for cervical cancer. Multiple partners is always bad because then that virus might be with a new partner, that HPV virus, and then they're transferring it to the woman, which is obviously bad. So you want to stay with one partner as much as you can, or obviously you want to practice safe sex or have protected intercourse. Those things are all risk factors if you don't do that. Also, smoking is a big risk factor for cervical cancer. Yeah, so there's certain things you just want to be cognizant of, to decrease your risks overall.
Absolutely. And with that being said, I know that OSF does so much when it comes to, screenings and raising awareness for this. But what's the best way for somebody that maybe, is younger out there, maybe in their mid-30s, and they have not even thought about this yet? What's that first step? Is it finding, let's say they have their primary care or they don't. Is it going to OSF's website to see if there are any primary care providers around, or how do those screenings work?
Yeah, you could do that. Go to our website. There's a great, site there. We have, physicians and nurse practitioners, both male and female. So a patient could pick who they're comfortable with, which is really great, in today's environment. And they're able also to, get appointments there through MyChart if they're already an established patient, say maybe with another doctor here at OSF. Or they could call, our number, the 618-462-2222 number, and just make an appointment. But those are all ways to reach out to us. But we're real fortunate. I work with I'm obviously a board certified OB-GYN doc. I work with an incredible nurse practitioner, Dina Brown. A lot of our other docs and nurse practitioners are female and also do annual women's health exams and pap smears. So we're able to get people in. All they got to do is reach out to us.
And, Dr. Sands, thank you so much for your time. I know that your day was pretty full, and I really appreciate getting some insights and awareness just on cervical cancer today, and would love to have you back on the show whenever you're available.
Sounds great. No, I appreciate your time.
No problem. And we'll take a quick pause here, right here in downtown Alton. We'll come back with more Daily Show. 9:41, a little bit of change back after this.